Rogers, and on behalf of the ADDitude team, I'd like to thank you for joining today's ADHD experts presentation titled Borderline Personality Disorder and Its Connection to ADHD. Leading today's presentation is Dr. Roberto Olivardia. Dr. Olivardia is a clinical psychologist and clinical instructor of psychology at Harvard Medical School. He maintains a private psychotherapy practice in Lexington, Massachusetts, where he specializes in the treatment of ADHD, executive functioning issues, and issues that face students with learning differences. He also specializes in the treatment of body dysmorphic disorder, obsessive compulsive disorder, and in the treatment of eating disorders in boys and men. He is the co-author of The Adonis Complex, which details the various manifestations of body image problems in men. So for today's discussion, how are ADHD and borderline personality disorder connected? They share overlapping symptoms, not the least of which is emotional dysregulation. And studies show that up to 40% of people with borderline personality disorder may also have ADHD. This overlap can lead to misdiagnosis and ineffective treatment plans. In today's webinar, Dr. Olivardia will identify BPD symptoms and explain how to distinguish them from ADHD. We'll also review comorbidity statistics, risk factors, and treatment recommendations. So we would like to begin today's webinar by asking a quick poll question of our live audience. Which of the following treatment options have you, as a patient or a clinician, tried to treat ADHD and or BPD? Please select your answers and comment in the text box under the video player to tell us a little bit more. And you'll see the poll results when you submit your response. We'll also review them during the Q&A session at the end today. So while you're doing that, I will just point out a few things. Live participants, you can submit questions anytime during the live event. To download the slides, click on the Event Resources section of your webinar screen. If you're interested in the Certificate of Attendance option, look for instructions in an email you'll receive about an hour after the live broadcast. And we will also make a transcript of today's event available in the coming week. If you're listening in replay or podcast mode, visit ADDitude.mag.com and search for podcast number 446 to access the slides, webinar replay, and certificate of attendance option, as well as the transcript. If you support the work we're doing here at ADDitude, we encourage you to visit ADDitude.mag.com/subscribe. Sign up in time to get our latest spring issue. I will note that it includes an article by Dr. Olivardia on eating disorders and how they manifest differently in males, as well as articles about brain training for ADHD, diagnosis of ADHD in women, and tic disorders in children. Lots of good stuff. Sign up now and share ADDitude with someone who could benefit from greater ADHD understanding. Finally, the sponsor of this webinar is Inflow. Inflow is the #1 app to help you manage your ADHD. Developed by leading clinicians, Inflow is a science-based self-help program based on the principles of cognitive behavioral therapy. Join Inflow today to better understand and manage your ADHD. You can click on the link on your screen to learn more. ADDitude thanks our sponsors for supporting our webinars, and sponsorship has no influence on speaker selection or webinar content. So without any further ado, I'm so pleased to welcome Dr. Roberto Olivardia. Thank you so much for joining us today and leading this presentation on borderline personality disorder and ADHD.
Great. Thank you for having me. As always, I love being a part of the ADDitude webinar series. And this is a topic that I do a lot of work in as I work with people with ADHD as well as individuals with personality disorders. So why are we talking about this topic? So first, as we know, ADHD rarely travels alone, that it's more the rule rather than the exception that people with ADHD will have a comorbid or associated disorder, whether it's depression, anxiety, substance abuse issues, eating disorders, learning disabilities. And today we're going to talk about one of those disorders known as borderline personality disorder. ADHD can sometimes get misdiagnosed as a personality disorder. Other times personality disorders can get misdiagnosed as ADHD. And sometimes people can have both, but only one of those two might be recognized. Now, even if the ADHD is diagnosed, what I've often found is that ADHD is very clinically underappreciated, especially in the treatment of personality disorders. And so part of our the mission, in a sense, is to really know how important the role that ADHD can play, whether it's in the development of a comorbid disorder and certainly in the treatment of that comorbid disorder. Clinicians often don't get adequate training in both ADHD as well as personality disorders. So there's a reason as to why we might see that misdiagnosis. Both can be very challenging conditions in their own ways, certainly for people who experience having ADHD and or borderline personality disorder, for family members and for clinicians who might not always have sort of the level of training of working with both of these conditions. There isn't a ton of research that looks at this comorbidity, but certainly having both has significant treatment implications. So I'm going to start by talking about what borderline personality disorder is, because I'm talking to an ADHD informed audience that I assume everyone here knows what ADHD is. So the criteria in the DSM speak to a pervasive pattern of instability of interpersonal relationships, self-image, and affects, and marked impulsivity beginning by early adulthood and present in a variety of contexts, as indicated by 5 or more of the following. So I'll go through each of these symptoms, and then I'm also going to talk about where that misdiagnosis can sometimes occur, and particularly where it might be more ADHD related versus more BPD related. So the first symptom is frantic efforts to avoid real or imagined abandonment. So people with BPD have a real deep fear of being alone and therefore being rejected and being abandoned. And that could play out in a lot of different ways and through their relationships, which I'll talk about in a moment, and could lead to very desperate type of behaviors to hold on to relationships, while at the same time might have a hard time holding on and connecting in those relationships. I should also mention too, just where the name comes from, that borderline personality disorder refers to a personality disorder in which someone could be at the borderline of psychosis and sort of reality. And now it's not a psychotic disorder like schizophrenia. And why they call it borderline personality disorder is when people are triggered, or when it's in certain venues, like interpersonal venues or whatnot, and where there is that unstable sense of self, people with BPD can experience thinking that isn't always reality-based. It's more based upon their assumptions or where their emotions are. And therefore, that's why we say it can kind of be on that border of not always kind of being grounded in a reality, but they think it's a reality. And that could be very difficult, obviously, to be in relationships, because if someone with BPD is responding to something and they're treating it as fact, and their partner is like, I don't understand what you're talking about. Like, that's not what actually happened. But to the person with BPD, it's what they felt. And sometimes the narrative can get distorted based upon those feelings. That's where that term borderline comes from. Now, with ADHD, you can talk to people with ADHD who also sometimes talk about efforts of not wanting to be alone and having a lot of sensitivity around abandonment. Now, a lot of times when it's just ADHD related, a lot of that could be an effort to avoid boredom. So there are some people with ADHD who are perfectly fine being by themselves and they can entertain themselves. But there are a number of people with ADHD who have a very, very hard time kind of entertaining and stimulating themselves. And so people become this sort of form of stimulation to prevent them from being in what I would say is sort of one of the more dysphoric states for people with ADHD, which is boredom. And so the idea of desperately connecting in relationships is that relationships are a form of stimulation. They're engaging. They sort of can make people feel very present. And so it's more around the issue of stimulation. So if somebody is properly, someone with ADHD is properly stimulated, they might not have that sort of frantic, sort of desperate effort of holding on, to people, or have those abandonment concerns or issues. So when I'm talking about this, it's pure ADHD, pure BPD. Now, of course, as I will talk about, people can have both. And so you might see this sort of mix. That even with patients I have who have both ADHD and BPD, sometimes when these behaviors enact, we will sort of try to tease apart, is this more ADHD activated or more BPD activated? And patients are fairly good at being able to kind of distinguish them once we have a proper frame as to what drives more of an ADHD related need to have people around versus a more BPD related. For patients of mine with BPD, they will often say that when they are alone, they feel like they don't exist, that there's this sense that people around them almost validate their existence. So it's beyond this issue of, oh, I'm just bored. It's that they don't even feel like they're selves, that they're here, that their sense of self is really in conjunction with other people, that when they're by themselves, they almost don't know who they are or don't really even feel connected to anything. So as a result of that, there could be this pattern of unstable and intense interpersonal relationships, and often are marked by extremes of idealizing relationships or devaluing relationships. So for people with BPD, the person, let's say, especially in dating relationships, initially could have a partner, and that partner could be the hero or heroine, in their lives, the end all be all, and everything is perfect about them until it's not. And then once it's not, it's this person is awful, and it's like very dichotomous in terms of how people with BPD look at other people and perceive other people. Now, part of that is because that's a reflection on how people with BPD view themselves as well, that it's this, what we call a projection of either I'm all good or all bad, and therefore other people are either all good or all bad. So there's a dysregulation of, in a sense, kind of relating and connecting to people, in that nobody is all good or perfect and nobody is all bad. So it's finding where do we fit kind of in that frame is very, very difficult for people with BPD. So it's often I've had, patients say, oh, I'm the kind of person that people either love me or hate me. Or I'm the kind of person that either loves people 100% and I'm loyal with you all the way, or I want nothing to do with you. There's that kind of dichotomy. And part of that is it's just difficult, because to be in the middle means we have to start trusting ourselves. We have to trust other people. We have to rely on resources of how do we sort of navigate something that is going to, as I'll talk about later with other symptoms, really pull upon some things that are very difficult for people with BPD. Now, where ADHD is implicated in this is sometimes you also can see that idealization, devaluation, but in a different form, particularly in relationships. The person with ADHD might idealize, let's say, a dating relationship initially, because it's like that honeymoon phase where they're almost intoxicated by a new relationship. And it's fun when you're getting to meet someone. There's so much stimulation. Again, a common theme that we'll hear with ADHD. And a lot of times the devaluation of, oh, I don't like that person, often will be in the form of that person isn't engaging me enough. Now, I can still, as someone with ADHD, feel a very strong sense of self and realize that an individual might not be engaging and boring, and therefore that person or relationship is now devalued. But that sense of self is strong, whereas someone with BPD, their sense of self gets very, very unstable. And they're almost, in a sense, trying to gain a sense of self through relationships. And so I need to be, if I, let's say, don't have a sense of self, well, I would want to affiliate myself with someone who I idealize, because they are an extension of me. I'm speaking in the voice of someone with BPD, sort of the psyche of someone with BPD is they are an extension of me. So I want to be an extension of something good. So once now, if I have BPD and I recognize some flaw, some imperfection, something that somebody did that I would label as bad, well, now I'm an extension of something bad. I don't want to be an extension of something bad. So now you are bad. I must cut you off. You can't exist because then I run the risk of feeling bad. I get contaminated. And so that's a very different process than with ADHD, where very routinely I might be working with someone with ADHD who said, oh yeah, I have this best friend. And then 2 weeks later, they're not the best friend anymore. And I'm like, oh, what happened to that relationship? They're like, yeah, they're kind of boring. And, you know, there wasn't much else to talk about. So in a sense, the honeymoon phase sort of dropped. Identity disturbance, and as I've mentioned before, very unstable self-image or sense of self with BPD. People with BPD really have a hard time kind of knowing who they are, and it's one of those things that can sound very bizarre to people who don't have personality disorders. Like, how do you not know who you are? How do you not understand that? But there are a lot of factors that play into why people develop BPD. But that lack of sort of developing a sense of self, so people would define themselves maybe more externally by what they do or by the relationships they have, but this sort of sense of a core part of who they are just isn't there, and it's something that through treatment has to be developed. Now with ADHD, where we can sometimes see that misdiagnosis, is people with ADHD can also have identity issues, and you can now have but it's not inherent in ADHD. So many people with ADHD have a very solid identity of themselves. Now it could be, I have a solid identity of myself as someone with ADHD. I have a solid identity of myself as someone who can be inconsistent about things or have executive functioning issues, but that's still a sense of self that's defined maybe through an ADHD lens. But we also know with ADHD that sometimes there are maturity lags, executive functioning delays, and things like that that might, certainly as someone is growing up, make it harder for them to sort of start to form their identity. They might be more late bloomers in that kind of intrapsychic way. Certainly because of executive functioning issues might make it harder to feel like an adult in ways and have those kinds of identities. And sometimes even finding their niche, because with people with ADHD, I think of it as, we don't have this huge bandwidth of where we might feel we fit. And so we're always looking for that place where, we fit. Like I call it almost like the Goldilocks syndrome that, when I was in third grade and we had to write a paragraph of a fictional character we related to, and I wrote Goldilocks having no idea why I was writing this. I mean, it's such a foreshadowing. But I said that Goldilocks, this bed was too small and this was too big, and this one was just right. And I had this sense of myself as someone that needed to find that just right place to really thrive. I didn't use it in that language in third grade, but that's what I was referring to. And so sometimes it's hard for people with ADHD to fully realize their identity until they find and get the right support and find that niche. But that's still very different than having a real unstable sense of self, because you can still have an identity as someone who is searching for their niche, searching for their place, looking to land in some ways. You're still a self, but you haven't grounded yourself. It's almost like you're the fully formed key, but looking for the lock. Someone with BPD might not even be the fully formed key yet. So they're not, and sometimes the key is designed based upon the lock. And so that's why sometimes people with BPD, their sense of self can really be malleable based upon where they think they're going to get the most love or the most validation or the most acceptance. One of the definite overlapping features is an impulsivity in at least two areas. So with BPD, you'll see impulsivity in spending, in sex, in substance abuse, reckless driving, binge eating issues. ADHD, this is probably the most common overlap. You see it in all of those things. And the mechanism is fairly similar, that with both people with BPD and ADHD, it's a method of grounding oneself, regulating one's emotions, and sometimes avoiding sitting with very difficult and painful feelings. That part is fairly similar in terms of the mechanism of why those things might be issues. Recurrent suicidal behaviors, gestures, threats, or self-harm, self-mutilating behavior is quite common in people with BPD. About 10% of people with BPD diagnosis will die by suicide. So it's a very high suicide risk. Now, with ADHD, we do know that people with ADHD do have a higher risk for suicide. And this is even after controlling for depression, anxiety, PTSD, and other disorders. So there is something, now I wouldn't say it's an inherent part of ADHD. In other words, most people with ADHD will not contemplate suicide. However, in whole group differences, people with ADHD as compared to people who do not have ADHD, when controlling for other variables, do carry a higher suicide risk. Now, a lot of times, though, the mechanism there in terms of differential diagnosis comes to what the meaning of suicide even means to them. So for people with BPD, they often will talk about wanting to die and really having this sort of desire of death, and really feeling like the world is just kind of doesn't work for them in the ways that they have a very hard time kind of regulating themselves into the world. Or because a lot of times patients of mine have told me that they feel numb, that they don't feel fully formed in ways. And so if you're walking around like a zombie, dying by suicide just seems like a formality. Now, of course, that's not at all what it is, and we want to prevent that as much as possible. But that's how a lot of patients I've worked with who have attempted suicide feel. With ADHD, when we're looking at just through an ADHD lens, and I have patients who have suicidal ideation, they often will say it's not so much that they want to die, they just don't know how to live. They'll often say, I don't know how to adult. And I don't know how to kind of figure this out. If someone just explained to me, either reduce some of the executive demands, or if I was in the job that I really liked, then I have a zest for life. It's just that it can just get really, really hard. And so a lot of times, even with self-harm behaviors, which people with ADHD are at higher risk for, usually then it's for sensation seeking or to relieve tension. And sensation seeking might seem very odd, given that it can be very painful in some forms of self-harm, like cutting. But for people with ADHD, it could be sort of a dopaminergic effect or dopamine release that can come from pain. And like we know, with ADHD, the ADHD brain is always craving stimulation. Not everything that's stimulating, though, is pleasurable. And so danger, risk, pain are very stimulating things. They're not pleasurable, but an ADHD brain might crave that. So when I'm working with someone where it's ADHD-related self-harm, they'll often say it's more to just relieve tension, to ground themselves. Again, not a healthy mechanism, to point out. We'll talk more about treatment later. Sometimes sensation seeking, whereas for BPD, a lot of the self-harm I'll hear more around ways of self-punishment, of hating oneself. It's often associated with more self-loathing, with sometimes dealing with a lot of trauma. And so, and sometimes to relieve the numbness, a lot of times patients will say it's not even that they're looking for this kind of dopaminergic effect as much as validation that they exist. And so cutting oneself produces pain, produces blood, which is like, okay, I guess I'm not a zombie because I'm bleeding, and so I am here. That's not something I won't hear from someone with just pure ADHD. Affective instability, you'll see a lot of mood issues in people with BPD, irritability, anxiety. BPD is highly comorbid with mood disorders like depression or bipolar spectrum disorders. In fact, that there are some conceptualizations that BPD is on the bipolar spectrum, but has these sort of different elements to it in terms of how it might play out interpersonally. And with ADHD, it's not, people with ADHD are at higher risk for emotional dysregulation. It's more context specific, though, that it's not sort of, I think of it like with the mood disorder or BPD, sometimes from the inside out, that people feel that agitation kind of internally and it just will like glob onto something. With ADHD, it's more something externally that happens that then triggers this the emotion, and then we know that people with ADHD can get emotionally dysregulated. I'll talk about in a second. And it's not this necessarily episodic thing that you might see more with BPD that gets triggered. And if it gets triggered with BPD, let's say in interpersonal relationships, it's usually not something that most people would sort of respond to or react to in that same way. So even if in BPD you see it could be context specific, let's say to situations in which people feel that they've been slighted, their perception of being slighted could be distorted, where they might be hypersensitive and kind of see signs of that when there might not objectively be signs of it. Chronic feelings of emptiness, as I mentioned, with BPD are common. With ADHD, I'll often hear that more when someone's just understimulated. So they might say, yeah, I feel empty inside, which I'll often hear from BPD patients, but then I'll ask, well, if your friend came over or if you were playing guitar, which I know you like to do you still feel that emptiness? And they'll say, oh, no, then it like just fills up, like that. So that's where it's modulated by the level of stimulation. Inappropriate, intense anger, difficulty controlling anger, very common in people with BPD, where it can really be marked in terms of, and very quite significant in terms of the level of anger or rage. Now, sometimes it's not always so external. I mean, there's this term called quiet personality disorder that's being used now to talk about sort of this inner rage that people can have that might not always show itself, but can come through in self-harm behaviors and just a lot of negative thinking that someone might think. With ADHD, again, that anger will be in response to something, and it might be just a failure to suppress or soothe feelings. We know with ADHD that studies show that, there's the amygdala, which is a part of the brain responsible for emotion and where our fight or flight phenomena gets triggered and our survival is housed. Now, when the amygdala gets activated, which actually studies on ADHD brains show activates quite similarly as people who don't have ADHD. The difference, however, with emotional regulation is the anterior cingulate cortex, which is a part of the brain that's implicated in the frontal lobe, connects to that amygdala and basically communicates with it by saying, okay, I know you're feeling bad, but let me properly distract you out of the emotion. Let me soothe you. Let me connect to why it wouldn't be in your best interest to tell your boss to shut up. It connects to those executive controls in the frontal lobe. And so it's associated with soothing that amygdala. Studies show that an ADHD brain has a delay in that anterior cingulate cortex. And if you think about with emotion, even a 10-second delay can cause a lot of damage emotionally. I mean, what can come out of your mouth or a fist through the wall or anything that can happen in even 10 seconds of a delay. So people with ADHD, their activation of the amygdala is actually not sort of uncharacteristic of what you would see with a neurotypical. Whereas with something like bipolar disorder, and I'm not familiar with studies on borderline personality disorder that have looked at this, but certainly with folks with bipolar disorder, that's associated with an overactivation of the amygdala. So it's hyperactivated, which is very different than what we would see with ADHD. And then with BPD, as I mentioned, that term borderline refers to sometimes transient stress-related paranoid ideation or severe dissociative symptoms. People with BPD, when again, it's more stress-related or context-driven, their thinking can get what I refer to as like slippery. And I don't mean that pejoratively, meaning that it almost like lacks boundaries in a way, and it starts to slip into paranoia or just pure dissociation where they're just not present and not here. With ADHD, as we know, inattention and distractibility are common core symptoms of ADHD. That can mimic dissociation, but is very different than dissociation. That's more in the context that if we're understimulated, we're going to be out to lunch and kind of not in the present moment, but we're connected to something. And typically with dissociation, people are just not always connected to anything, or might be connected to a particular traumatic experience. So that takes them out of the present moment. And it's not always regulated by the level of stimulation or what's in front of them. Whereas to someone with ADHD, if they're connected to something more internally or externally, they can feel very grounded and won't have those kinds of symptoms. Paranoia is also not an aspect or characteristic of ADHD. So that sort of gives you some of the differential. Now, what we know about an ADHD brain is, it implicates dopamine and dopaminergic deficits, GABA, which is an inhibitory neurotransmitter that an ADHD brain is typically low in GABA. With what we know about a BPD brain is that it also tends to have dopaminergic dysfunction. Now, it's not so clear as to how it sort of works, but we know that there's something regulating levels of dopamine that could be inconsistent or dysregulated in people with BPD. There's also deficits in oxytocin, and oxytocin is also known as the bonding hormone or chemical that's implicated when we fall in love with someone. And there are studies that show dysregulations of oxytocin, which makes sense that people with BPD can get very, very almost like glued into relationships or very disconnected too quickly from relationships. BPD brains are also predisposed to impulsivity, emotional instability, poor interpersonal functioning, attentional and memory deficits, and poor inhibitory control, and low emotional processing. And all of those things really interfere with making very good, solid social bonds. So it makes sense as to why relationally these things can start to play out. Now, where ADHD and BPD intersect is that there are a number of studies that are starting to look at this. Now, BPD affects about 1.4% of adults currently. So that's the sort of general prevalence rate. Although, with any of these prevalence rates, I often think it's probably higher because it's something that often, again, not all clinicians are trained to assess for BPD, might not have that be part of their even graduate school training. And because there are a lot of comorbidities that come along with BPD, we're talking about ADHD, but it could also be with depression, anxiety, substance abuse, bipolar disorder, that sometimes BPD can get underdiagnosed. Now, studies show that a number of people with BPD also have ADHD when looked at. Asherson found 20% of the sample of people with BPD had ADHD, and another study, over 40% of people with BPD had a comorbid diagnosis of ADHD. 16%, 38%, these are significant comorbidity statistics that you would see that would be a higher than by chance notion that you would see ADHD in these samples. So we know that there's something that sort of brings these two disorders or conditions together. There's a significant association of ADHD to later develop BPD. And in this particular study in 2015 found that to be the case only in women. But I would say in my clinical experience, I see it with both men and women. And another study found that people with ADHD were more likely to be diagnosed as BPD over controls, people who did not have ADHD. Fisher found that children with ADHD are at greater risk of later developing BPD than what would be expected by chance. Studies find that people with ADHD can be, when looking at samples of people with ADHD versus people with BPD or people who have both, the studies show that when an ADHD sample was compared to a BPD sample, there's a lot of alphabet here, that the ADHD individuals were worse at goal and task persistence. Ferrer did a study looking at a combined group of people who had both ADHD and BPD and compared them to just people with BPD, and found that the presence of ADHD was associated with higher substance abuse disorder, particularly cannabis dependence, antisocial personality disorder, obsessive compulsive personality disorders, and suicidal behavior. So that's where the presence of the ADHD can have a compounding and exacerbating effect on whatever present BPD symptoms there are. When looking similarly at comorbid disorders, they found that people with BPD were at higher risk for mood disorders than people with ADHD and BPD. So interestingly, the presence of the ADHD was associated with lower risk of mood disorders, as well as lower risk of panic disorder, which is interesting. Similarly, when looking at people who are combined versus people with BPD, that found that the combined group had a higher likelihood of lifetime aggression, oppositional and disruptive disorders, other cluster B personality disorders like antisocial, obsessive compulsive personality disorder, and ODD diagnosis. STEP found that having ADHD and oppositional defiant disorder at age 8 uniquely predicted BPD symptoms at age 14. You'll see higher impulsivity in groups, again, where the ADHD is present, higher substance abuse disorder, as well as aggression. Now, in a study that looked at a combined group of ADHD and BPD versus just ADHD, so looking at what the presence of a BPD diagnosis could be, that was associated with an increase in the presence of all mood disorders, depression, dysthymia, bipolar disorder, antisocial acts, alcohol and drug dependence, but with the substances only with cannabis dependence, smoking cigarettes, criminal behavior, thought disorder, less schooling, and more expulsions, suspensions, and out-of-district placements. So that's what the presence of BPD exacerbated all of those things in samples of people with ADHD. Phillipson's found that when looking at indices like self-perception, emotional regulation, self-destructiveness, hostility, boredom, loneliness, intrusions and intrusive thoughts, the highest scores were with individuals with BPD, which significantly differed from people with ADHD, which significantly differed from controls. So it almost had this hierarchical rank. Self-destructive and emotional dysregulation were the biggest differences between ADHD and BPD. So what does this mean? I mean, in terms of how we think about this comorbidity, are these different expressions of the same disorder? Is ADHD a precursor to it, or can be an early manifestation in some people, not all people, to develop BPD? Are they distinct disorders that share just some genetic and environmental risk factors? Are they just two independent disorders that kind of reinforce each other? Does the presence of one increase the risk of developing the other? And then certainly what treatment implications? So these are the risk factors that have been found that make ADHD have a higher risk factor for developing BPD. Now, keeping in mind that most people with ADHD do not have borderline personality disorder, but there is a higher risk factor. And why is that? In ADHD brain, you'll often see parts of the brain where impulsivity and emotional control is a problem that can make it risky for BPD. As I mentioned, that anterior cingulate cortex and emotional processing and emotional soothing, levels of glutamate in the brain that are implicated in sort of dysregulated metabolism of energy, particularly in the frontal lobe, serotonergic or serotonin and other neurotransmitters that also tend to be impaired sometimes in ADHD brains as well as BPD brains. We know that ADHD and bipolar disorder also have a comorbidity. About 20% of people with ADHD have a bipolar or bipolar spectrum disorder. And as I mentioned before, BPD is, for some people, conceptualized almost as a variant of bipolar disorder. Now, other traits we know about ADHD, impulsivity, emotional dysregulation. For those people who have poor reading of social cues, who have ADHD, there could be this negative feedback loop of really negative social experiences that can make it hard for people with ADHD to kind of practice being in longer term relationships. And therefore that relational part of their lives can get quite disturbed and there could be dysfunction in, which could put somebody at risk for BPD. Poor peer relationships, difficulty tolerating negative affect. People with ADHD are more likely to have trauma histories, and trauma is one of many contributing factors to what we would see in individuals with BPD. History of being bullied, low self-esteem, which if you have a low self-esteem and feel stupid because of executive dysfunction, learning disabilities, some of the symptoms of ADHD, it's not hard to imagine that your sense of self now first gets developed as someone who's stupid, and then eventually gets just developed as just someone who just doesn't, belong in a lot of ways. There are genetic influences, both with ADHD as well as BPD, so just inherent of parental genes, and the emotional and environmental impact of emotionally dysregulated parents. Now, we know with both ADHD and BPD that there are genetic underpinnings. So if you are someone with ADHD that has or had a parent or both parents with ADHD, where their ADHD was not treated and involved a lot of emotional dysregulation, you're now not only inheriting perhaps certain genes, but you're also now enduring some trauma and enduring some of that emotional invalidation and chaos. And that can certainly make it very, very difficult to form identity if you're not feeling safe. Trauma is a major factor to making it very difficult to sort of form identity, at least through the timeline that we're supposed to. Having a trauma history doesn't mean you will never form an identity, but it just will take a different process. ADHD can be a stressor that gets in the way sometimes of parents who themselves might have untreated ADHD to really attune to their child's needs, which leaves that child feeling invalidated, neglected, which could then set up that child to need desperately other relationships to sort of validate them. So with BPD parents, they can neglect a child who then doesn't develop that normal identity, as well as other defenses that because, with emotional dysregulation, you're not kind of tolerating some of the nuances of things. You don't have the safety to, so you have to split, like, is this person good or are they bad? And other defenses that people might engage with. It can be very difficult, let's say, if you did something bad, to own that, and without feeling like it makes you a bad person. And for people with ADHD who, let's face it, a lot of us have done, I haven't always been an angel, but there's a difference between doing kind of bad behavior, mischievous behavior, and seeing yourself as an evil person. And if you do start to have that narrative, that is the kind of narrative that places somebody at risk for BPD. And the splitting kind of behavior, I like the idea, mom is mad at me and telling me I'm bad, mom is perfect, therefore I must be bad. But then that could vacillate with I'm all good, therefore mom is all bad. And a lot of times with BPD, it's that person is making me feel bad, therefore they are bad and I'm good. It can have that sort of splitting effect. There's a poorer prognosis when people have both, but I want to emphasize when oftentimes it's because one of those conditions is not even diagnosed and let alone not treated. Suicidal ideation behaviors increase risk when people have both conditions. Again, oftentimes one is underdiagnosed or not treated. Impulsive suicides are higher at the presence of ADHD. In terms of treatment, you have to treat them both because from my lens, ADHD is just there. Like you're always having to treat the ADHD because to me, I think of ADHD as the lens of which everything else is sort of being seen through. And untreated ADHD will undermine the treatment of everything else. If the ADHD is triggered, it's associated with a decrease of BPD symptoms, with better functioning, with better control over behaviors. Also, it's more likely to benefit from BPD treatment when the ADHD is also being treated, because even doing DBT, for example, which are mindfulness skills, emotion regulation skills, interpersonal functioning skills, and distress tolerance, to even attend to that, to cognitive behavioral therapy, addressing our negative thought patterns, you have to have a certain level of executive function, even to do that kind of work. So the ADHD to me is always has to be treated in conjunction with what you're working with. So DBT, which was really designed for people with BPD, but now has been shown to really help not only people with any diagnosis, but everybody. I mean, who can't benefit from mindfulness skills, interpersonal skills, regulating our emotions, and tolerating distress? I mean, and studies have shown that it can be helpful in a multitude of different conditions. CBT, executive functioning coaching and training for people with ADHD, psychotherapy, and particularly with BPD, psychotherapy will often address what's called like transference and countertransference, where the relationship with the therapist is a very important tool of treatment in terms of how the person with BPD can regulate themselves in a relationship, that the actual treatment relationship is a significant part of the treatment. Couples therapy, medications. There are no specific medications that are approved for BPD, but typically people with BPD will be on SSRIs, mood stabilizers, sometimes antipsychotics to help control mainly the mood regulation or self-harm behavior, and developing a crisis plan. As I mentioned before, and I'll go through these quickly because I want to leave some time for some Q&A. DBT, very, very helpful. And there are a few studies out there that have looked at people who have both ADHD and BPD who were enrolled in a 13 to 16-week DBT group and found increase just higher functioning in both conditions, both the ADHD as well as the BPD. So again, DBT to me is almost one of those things that it's like, it can help everyone, you know, to learn assertiveness skills and not judging oneself. Because we know that with ADHD, there can be a lot of self-judgment around, you know, why can't I get this done? And how come I can't control my spending or my alcohol use in that way, as opposed to understanding, okay, this is how my brain is wired, and my brain makes it more likely to get rewarded by these kinds of things. And I have to then make sure I get the right support and understand that, but without moralizing it. And with BPD, it's also that sort of non-judgment of, because people with BPD can shame themselves a lot around like, oh, I feel too much, or, you know, what's wrong with me? I'm a loser. I can never have a relationship, as opposed to, okay, relationships are difficult for me. Why is that? Let me understand that. Let me understand that there is, you know, this biological element and environmental element. And for people who have had trauma, to sort of acknowledge that trauma kind of can really mess with the fabric of identity, and be kind to themselves in the process. These are some good books on BPD that I would recommend. BPD, A Guide for the Newly Diagnosed, the Borderline Personality Disorder Survival Guide, I Hate You, Don't Leave Me, which has been around for years, but still holds true today in terms of the information in there. And that title speaks to that kind of vacillation sometimes you'll see in relationships. Sometimes I Act Crazy, Living with Borderline Personality Disorder. Marsha Linehan, who developed DBT. These are sort of the classic treatment kind of worksheets and books. And particularly with some of these worksheets, they're very, very helpful for patients where in the back of, I think it's the skills training manual, she has all the different emotions and then a whole section of what triggers these emotions, what do they feel like physiologically, and so on. Because sometimes people don't even know how they feel, like how to even identify that feeling. BPD in adolescence. Now, typically in the DSM, it says you have to be 18 or over to have a personality disorder. And I think especially where ADHD is in the mix, we do want to make sure that if BPD is diagnosed prior to 18, that it's really been ruled out that it's in fact BPD and not ADHD or something else. But BPD researchers are showing that you can see some of these symptoms in adolescents. And this is a book, Stop Walking on Eggshells, which is a classic for partners of people who are in relationships with people with borderline personality disorder, because it can be very difficult for them, and they need support. They don't always know what to say, and sometimes can feel like they're always damned if they do, damned if they don't. And this book is the book that partners I have worked with, or if I'm working with the patient with BPD, that they've given to their partner and they feel a lot of validation in. National Education Alliance for Borderline Personality Disorder, wealth of resources that you can find more information about BPD. So we have about 10 minutes for Q&A.
Wonderful. Dr. Olivardia, thank you so much for that. It was truly a masterclass on BPD. It was thorough and illuminating. We got a lot of great questions. I will quickly thank our sponsor, Inflow, once more for sponsoring this webinar today. And I actually want, I think everyone can reference the results on our survey, but I really want to dive into these questions because there were so many good ones. And to start off, please correct me if I'm wrong, but BPD can be diagnosed as young as 12 years old. Is that right?
Well, this is where technically with personality disorders that it was originally sort of formed that it would rule out anything before 18 because there are so many other factors. I mean, just puberty alone can be very emotionally dysregulating. Identity is forming in adolescence, so it's not like any of us are necessarily fully formed identity-wise. So, you know, some circles would say, no, that's way too young to diagnose BPD. However, that book I had mentioned with adolescents will say that you can see those traits, however, in younger people. I think that the only thing I would just caution with an actual diagnosis is that when someone is diagnosed with a personality disorder, it can be one of those disorders that really follow people in ways that where it's now only looked through that lens, and where I have seen a lot of misdiagnosis of people who didn't understand ADHD and they were diagnosed with BPD and they didn't have BPD. They just had ADHD. That we just want to be very, very careful. But BPD traits, absolutely. I mean, I've worked with individuals 12, 13 who engage in sort of these behaviors interpersonally that are not related to their ADHD might be exacerbating, but are kind of more these precursors to what you would see with BPD.
Okay, we received a number of questions from parents of teenagers who are exactly as you said, really grappling with differentiating between what is hormones plus rejection sensitive dysphoria plus,
yes,
ADHD versus the bipolar and not wanting to jump to a diagnosis. As you said, are there a few highlights? You recommended that great book specifically on teens, but a few highlights for these parents, there were so many of them, that could help them to just, sort out what really could be some red flags.
Yeah, so rejection sensitivity dysphoria is not a clinical diagnosis, but it's a term that's used in the ADHD community of individuals that really feel this pain around sort of being rejected, and it can really plummet, their mood. Where I would say where we start to see BPD more than that emerges very differently than what we would see with ADHD is sort of this kind of projection, we call it, like the defense mechanism of projection. Now, mind you, as I'm about to say this, a lot of parents who just have any teenagers can relate to this. This is why we kind of have to be nuanced about it. So, for example, the person where it's just ADHD feel a sense of rejection sensitivity, and they're like, oh, I feel, bad and I'm rejected, and, this doesn't feel good, and they're longing for affiliation, and they're longing for connection and validation and being accepted. Now, they might still, though, have a sense of self, though, like of who they are. They might feel, though, that who they are is being rejected. So if I'm into video games and someone says, oh, video games are for losers, and I feel the sting and the pain of that rejection that really can get me down. But I see myself in that identity as someone who likes video games. Versus with BPD, that rejection sensitivity can play out in a different way, where if now I'm rejected, then it's almost like however I've defined myself is just now, it's almost like chameleon in some ways. And it's not even conscious sometimes. It's like I now don't know who I am and who I'm supposed to be, because who I'm supposed to be is, or who I am rather, is who people want me to be, which is a little bit different than someone who's like, this is who I am, but I'm being rejected and that doesn't feel good. So the person with BPD, sometimes, especially when it's more internal, on some level can be social chameleons. Like they can be everything they feel someone needs them to be at all times. And there could be almost an adaptive element to that. The problem is that for that person, they don't really have a solid sense of self. They are whoever they need to be for a specific person. The other thing is that with emotions, the person with BPD will start to say things like, you made me feel this way, and, have a very hard time with sort of tolerating kind of that things aren't always so dichotomous in that kind of way. And sometimes attribute and distort situations to sort of match the emotion. So when you start to see a real distortion of, let's say if somebody who has a rejection sensitivity, and it's really, strong, they might say, with BPD, you'll often hear, oh, well, you said that comment, and someone would be like, I don't know what you're talking, I've never said that comment. And then the person with BPD gets enraged because they're like, what are you talking about? Like, are you then questioning kind of my reality? Like, you did say that comment. And to that person, they really have interpreted that. It's not that they're just lying. It's almost like the things get distorted to fit the emotion. And this is, again, why it's called borderline, is that there's almost this, like, it can almost feel psychotic in some ways. It's like, I don't understand what you're talking about. Whereas with ADHD, someone might comment on something that people could objectively agree upon to be like, yes, that kid in the playground did say that, or yes, your boss did say that. And maybe to the person with ADHD, it's felt more deeply. People with ADHD could be highly empathic, which is an adaptive element to it. So they need help kind of regulating that. With BPD, it starts to take on different forms. People who have BPD also, I notice as just one differentiating factor, are like really can hold grudges. And it's almost like, and it's not, again, this sort of willful, like, it's almost more this sense of you are now bad and like I can never forget that. Whereas people with ADHD, I find, are more malleable and more flexible in terms of, even if someone has actually betrayed them or actually rejected them, there's sort of more of a malleability of being able to kind of look at that from different perspectives.
Those examples were so helpful. Thank you so much. That was great. I do not need to tell you, but, our understanding of ADHD has so advanced in the last decade or so, really just how much comorbidity is in the mix. And yes. I think that one of the areas where there's a lot more understanding now than ever is in the world of trauma. So we did get a number of questions about PTSD and PTSD. Just wondering, for those who are looking to really sort out their diagnosis, are there a few things that you would like to see a diagnosing clinician consider when weighing, ADHD plus versus BPD? Like, for those who are going to seek a diagnosis, some things that really you would like to see the evaluator take into consideration.
Yeah, so trauma absolutely can, we know that people with ADHD have a higher risk of various kinds of traumas. So first we want to assess even that, in terms of, are these issues of inattention, emotional dysregulation, ADHD, or is this, trauma, in that kind of way, in terms of, because let's say if it's more trauma-based, a stimulant medication doesn't help. If someone doesn't have ADHD and they have attention issues due to intrusive thoughts about trauma, stimulant medication is not going to, it could actually make it worse at times. Now, where BPD is concerned is lots of people with BPD have histories of trauma, and BPD is also a diagnosis that unfortunately is highly stigmatized, even still, when people are like, oh, and it's not only highly stigmatized, but it's highly gendered in its stigmatization of, women, and sort of like the hysterical, difficult, borderline, patient or woman. And the truth is men, what has typically happened diagnostically is men tend to get diagnosed with narcissistic personality disorder or antisocial, and the women get diagnosed with BPD, when in fact they're very, very similar. I've treated many men who have borderline personality disorder. And what I hope that people who take away from this is not to feel stigmatized by any diagnosis, but really look at the diagnosis as an understanding, and of course to guide them to the right treatment. And with trauma is that you can have trauma which then develops into BPD, and it's both, but it's understanding that the BPD is kind of this like result of this trauma. In the same way that for some people, let's say who struggles with a drug addiction, that might come from like up to 50% of people with bipolar disorder self-medicate with drugs and alcohol. And so if we understand that, yes, the drugs and alcohol are its own issue, but it's stemming from self-medicating this other thing, but both of them are there and they're valid and they both need treatment. And that could be the case too, where trauma, is with BPD. But most people who experience trauma do not develop BPD. And so whereas studies will show that most people with BPD have a history of trauma. So it doesn't go the same way on both ends. So most people, again, who experience trauma do not develop BPD. Most people with BPD have a history of trauma. So what distinguishes in terms of the trauma history could be very nuanced in terms of how much that trauma basically intersected with identity development and how a person develops their sense of self. Because let's say if you have, I've worked with patients, let's say, who have been sexually assaulted or abused by somebody outside of the family. And of course, that's a traumatic impact. But if they had the right support in their family and they had a solid sense of who they were and that this was this bad person who did this horrific thing to them, that doesn't necessarily have to rip into the fabric of their identity. Now, if you have another individual who, let's say, is assaulted by a parent who they are living with day in and day out, who they're in fear of, where there's a terror, that now has a different way in relation. It doesn't make, and I always want to make sure to say, it doesn't make one trauma worse than the other. It's like we don't ever rank trauma, but in terms of understanding the implications of that traumatic experience can have a greater implication on identity development, which then puts someone at higher risk for BPD. So it often will take a lot of processing of the trauma to understand what implications and ripple effects that trauma might have. Like even with veterans, like not all veterans are diagnosed with PTSD. And even though all of us can agree that experience has so many traumatic elements to it, but when I have worked with veterans who have PTSD, it's really understanding the nuances of, for some of my patients, it could be that they felt helpless in saving somebody. And so that trauma plays out in their lives of feeling like they have to make up for that almost, desperately. For some people, it's a sensory thing of certain senses. And so it can be very nuanced to sort of tease that out. But trauma is always important to just fully assess and understand also the meaning that someone makes from that, because there are lots of people who experience traumatic events who it really doesn't become sort of a huge part of their narrative and their lives if they've had treatment, if they've had support, if they've sort of kind of integrated it in a different way. So everyone has their sort of unique story around that.
Thank you so much, Dr. Olivardia. This is such a nuanced and difficult topic. I feel like I've learned so much. I know reading the comments from our attendees, a lot of people have really learned a great deal today. So thank you so much for leading this discussion. We hope that everyone here will join us for future ADDitude webinars. We do have one next week, and it's on the topic of ADHD then and now, just how our understanding of the condition has evolved with Dr. Dave Anderson. So we hope you will join us for that. In the meantime, I'm Dr. Olivardia. Thank you again, and we hope to see you again soon. Have a great day, everyone.
Take care.